Welcome to our first session of day 2 of our MCPOP Potpourri, Perinatal Potpourri Conference. We are very excited about our morning session this morning. We have Dr. Brian Bateman here to give us a wonderful presentation on using big data to study the safety of medications in pregnancy. So Dr. Bateman, I will pass it off to you. Very excited about what you're going to share with us.
All right. Thank you, Savannah. It's a pleasure to be part of this conference. Gonna just pull up my slides. Let's see. Bear with me for 1 second. Okay. Hopefully, Savannah, can you see
Looks
them?
great. Yep,
It's
looks
great.
great.
Okay, terrific, terrific. Well, again, thank you for the invitation to be part of this meeting. So, what I'm going to talk about this morning is the use of large databases to study the safety of medications in pregnancy. We'll start off by just talking about why it's important to study the safety of medications in pregnancy. I know all of you who work in perinatal health probably don't need this component. You recognize how important it is to understand the safety of medications and the need for good data to help counsel patients regarding medication use in pregnancy. And then we'll talk about some of the approaches that are used, some of the study designs. And then I'll close that part out by talking about work that our team has really been leading over the past decade, and that's using large healthcare utilization databases, claims data sets to study the safety of medications. And then I'll go through several example studies using these big data approaches. A study looking at the safety of statins during pregnancy, one looking at ondansetron, the antiemetic. We'll talk about some recent work that our group has done looking at opioid use disorder treatments. And then as kind of a glimpse to the future, an area that our group and others are increasingly interested in understanding the long-term effects of in utero exposure, prenatal exposure to medications on outcomes for the infant. Okay, so why study the safety of medications? Well, first, medication use is incredibly common. Data that we have from Medicaid suggests that 80% of pregnant patients are dispensed one or more prescriptions during the course of pregnancy. If you look at commercially insured patients, it's a little bit lower, but still quite high. And medications have been implicated in a wide range of adverse pregnancy outcomes, including preterm delivery, the development of preeclampsia, gestational diabetes, neonatal hypoglycemia, and postpartum hemorrhage, just to name a few. But the adverse effect of medications that we're most concerned about is congenital malformations. And that's because congenital malformations are a serious contributor towards lifelong disability. We know that congenital malformations account for about 1 in 5 deaths during the first year of life, and they really, for those that survive into childhood or adulthood, confer a really major burden. And if you look at in terms of illness, and if you look at the disability-adjusted life years associated with congenital birth defects, a standard measure used in public health to assess the impact of from a public health standpoint of a complication. You can see congenital birth defects results in a number of disability-adjusted life years lost that's on par with stroke, COPD, HIV, AIDS, or chronic kidney disease. So really important from a public health perspective. And the reality is we don't have great safety data on many medications. There was a systematic review that was published in Pharmacoepidemiology and Drug Safety, where they looked at the 54 most commonly prescribed medications during pregnancy and then evaluated the quality of the evidence regarding teratogenic risk. And they found that only in 2 of the 54 most commonly used was data considered good to excellent. A further 18 medications had fair to good data, but that means that 34 of the 54 most commonly used medications in pregnancy, the expert committee that looked at the data found that the quality of data regarding teratogenic risk was graded as less than fair in quality. And this is important in terms of understanding the safety of medications, not just in terms of whether medications can be used safely during pregnancy, but whether they can also be used in women of reproductive age. We know that in the US, about half of all pregnancies are unplanned. And so there's concern if a person is using medications and then becomes pregnant, they may continue to use those medications during the early periods of pregnancy, the period around organogenesis, before they can be seen and counseled by a clinician. So understanding the safety of medications has real impact in terms of what we recommend to people who may become pregnant. So how then can we study the safety of medications? Well, for a long time, the most commonly used approach was registries, and in registries, patients are prospectively enrolled, generally in early pregnancy. A common strategy is enrolling patients who call a drug safety hotline or a pregnancy information hotline. And then the patients are followed throughout pregnancy who are taking medications, and then the outcomes in the exposed infants are assessed. And while this is a really important design, and we can learn a lot from this design, there are important limitations, and those include limited power to detect effects of not large magnitude, but still clinically consequential. A limited ability to control for confounders. You often don't have a good control group that allows you to account for confounding by indication or other conditions that might be associated with the medication. And then these studies are very costly to perform, both in time and expense. And then I listed some of the common, or some well-known registries, including the North American Anti-Epileptic Registry. Some of the drug manufacturers have pregnancy registers like Merck or GSK. There are others that are out there as well. Another approach, and this has also been extremely important in helping us understand the safety of medications in pregnancy, is the case control design. And then a good example of this is the National Birth Defects Prevention Study run by the CDC. And in the case control design, pregnancies that result in infants born with malformations are matched to controls where the infant's born without malformations, where the infant is born healthy. And then women who gave birth to these infants are interviewed retrospectively about their pregnancy exposures. Sometimes, in the case of the CDC study, up to 2 years after delivery. And then the frequency with which the patients who had infants with malformations, the frequency with which they took a particular drug is compared to the frequency with which the control group took a drug, and then that can be used to estimate the relative risk associated with taking a particular drug. And again, while this has been a very important study design that we've learned a lot from, one of the major limitations is the potential for recall bias, the concern that women who have infants born with malformations are going to be more likely to remember the medications that they took early in pregnancy, particularly if you're talking about interviewing them a year or 2 years after they delivered, than women who had healthy born infants. Because of the case control design, it can be used to estimate relative risks, but not risk differences. And risk differences is often very important in contextualizing the degree of excess risk associated with using a particular medication. They're limited sometimes in the ability to control for confounders. You're limited to the confounders that are collected in an accurate manner in the study. And then, like registry studies, are quite costly to perform. So there's been growing interest that, as I mentioned, our group has really been involved in developing methods to use these data in using in performing cohort studies that are nested in healthcare utilization data, the data that are used for billing and reimbursement for healthcare services. And as an example, we've been able to create now a cohort of about 5 million pregnancies where we have information on the mother from throughout her pregnancy course, and then we create linkages to infants. And with Medicaid and commercial insurance claims, we've now created a cohort of about 5 million pregnancies where we have information for pregnant patients across their pregnancy course, including the medications that they were exposed to, and then information on the outcomes in the infants. And these claims data are quite powerful. They contain information on outpatient diagnoses, inpatient diagnoses, laboratory studies, imaging services, and then, as I mentioned, and really central to the work that we've performed, medication dispensing by pharmacies. And there are a number of advantages in using these big data to study the safety of medications. The data sets tend to be large, allowing us to evaluate relatively rare exposures and relatively rare outcomes in certain circumstances. They're population-based, so there's no concern around selection bias. They contain prospectively collected drug exposure information based on pharmacy fills, so there's not concern around recall bias like in the case control design. There's information on a wide range of confounders that are recorded in the claims, including comorbid medical conditions, other medication exposures. They're very efficient to use these data, both in cost and time, to study safety of medications. The design is longitudinal, so you can estimate both relative risks and also risk differences. So you can look at the absolute increase in risk associated with the medication, really important in informing risk-benefit discussions. And then you can study multiple exposures and multiple outcomes, really limited only by what's coded with fidelity in the claims data. Okay, but there are important limitations or aspects of study design that need to be attended to when using these data. So to frame up that discussion of what the things that we need to be attentive to, I'm going to pose a typical study question that we might be interested in. So typically when we're studying the safety of a medication in pregnancy, we're interested in the impact of that exposure on outcomes. So an example might be studying the safety of metformin, the anti-diabetic agent, on an outcome in the fetus, for example, congenital heart defects. And of course, you can't estimate this association directly, right? Because it's heavily confounded. There are a number of factors associated with both the exposure to metformin and the outcome that we're interested in that have to be measured and adjusted for in our analyses. For example, patients that take metformin have diabetes. They tend to sometimes have relatively severe diabetes, both of which are very strong risk factors for congenital heart defects in the infant. They also tend to be used in patients that have metabolic syndrome, so have hypertension. There's a higher use in patients undergoing IVF or patients who are of advanced maternal age, all of which are risk factors for congenital heart defects. So when using claims data, we have to think about the impact of evaluating all three of these components of a study design: exposure, outcome, and confounders, and the way in which we need to do that in claims data in order to generate a valid causal estimate, which is ultimately what we're interested in doing, which allows us to speak to the safety of medication. So there are a number of challenges in estimating causal effects in claims data. The first, and this is around outcomes, is the potential for outcome misclassification. For example, we know in claims data, a single diagnostic claim does not necessarily equate to the presence of a condition. There are situations where the infant may have a claim for a rule-out diagnosis, for example, rule-out congenital heart defect, and that would be coded. And so if you define congenital heart defects based on a single claim, you would have really quite poor accuracy around the definition of that condition. So there's a need to define algorithms in using claims data based on diagnostic codes and procedures. There's a need to then validate these algorithms based on chart review, and to define an algorithm ultimately that has a high degree of specificity, because we know if an algorithm has a high degree of specificity, even with potentially limited sensitivity, this will yield unbiased relative risk estimates. Another concern is around exposure misclassification. I mentioned that in claims data, we define exposure to a medication based on dispensing of a medication. Dispensing does not necessarily equate to real use. There are times that patients fill a medication and then they choose not to take the medication, or they may choose to fill a medication just in case they need it. For example, an opioid after a surgery, they may fill the opioid prescription and hold on to it just in case they had pain that was severe. So we have to account for that in our design. For example, exploring multiple exposure definitions. A way to do that would be to look at multiple fills of the same medication during the period of interest, on the assumption that if patients refilling the medication on a consistent basis, they're likely taking it as prescribed, or doing more sophisticated bias analyses to account for exposure misclassification. Likewise, there are challenges around confounder, either ascertainment or misclassification. And our approach to dealing with this is generally to include not only the direct diagnosis of a confounder in claims data, but also markers of the confounding condition or markers of their severity. For example, if we're interested in diabetes as a confounder, we'll not just include the diagnostic code for diabetes, but the diagnostic code for diabetes and codes for complications of diabetes, codes for medications that might be used to treat diabetes, like insulin, and then incorporate that into a propensity score or some other approach that allows us to adjust for those factors. And an example of really generous inclusion of proxies in an automated fashion is high dimensional propensity score, which automatically scans the claims data to identify both confounding conditions as well as proxies for confounding conditions and incorporates them into a propensity score. And likewise, there are a number of sensitivity analyses we can use to help look at the or improve our confounding control. For example, propensity score calibration based on external data. We can model the potential impact of missing confounders and see what the impact on our risk estimates are, or even looking at negative controls that have potentially similar confounding structure, but where exposure to the medication was outside the etiologically relevant window. So a number of ways that we can help address this issue of under ascertainment or misclassification of confounders. Okay, so that's kind of the framework and some of the methodological challenges associated with using claims data. I'm now going to talk through a number of example studies that our group has performed, where we've used these big data approaches to study the safety of medications. And the first two examples both resulted in label changes by regulatory agencies, but in very different ways, as we'll discuss, and which is quite interesting. So the first example is statins and congenital malformations. So statins historically were classified by the FDA as category X under the old nomenclature for describing pregnancy risk. And category X means that they're considered contraindicated for use during pregnancy. And this was based on animal data showing the potential for toxicity associated with statins, as well as the known role of cholesterol biosynthesis in prenatal development. But prior to our study, there were very few data in humans, and those studies that did exist yielded really mixed results. They derived primarily from registries, very small cohort studies, and spontaneous reports, none of which did a particularly good job of accounting for confounding conditions. And this question was important, or is important, because not only does it inform use during pregnancy, but also in women of reproductive age, as we talked about before, who may have hypercholesterolemia. But it's also statins have, because of their pleiotropic effects on endothelial function, they're thought to potentially have a role in preventing preeclampsia. So this is the study that we published back in 2015 in the British Medical Journal. At the time, our cohort of Medicaid patients had just under 900,000 pregnancies, where we had longitudinal information about the mother and then a linkage to the infant. Of these about 900,000 pregnant patients, 1,152 were statin exposed in the first trimester based on filling a statin during the first trimester. And then our outcome of interest was congenital malformations. We looked at congenital malformations overall, as well as organ-specific malformations. And this was defined using an algorithm that had high specificity that we confirmed based on chart review, had a high degree of specificity, including codes for a particular type of malformation on 2 separate dates, or 1 code plus a corrective surgery. And then to control for confounding conditions, we defined 50 covariates that were drawn from the claims, including maternal demographic characteristics, maternal comorbidities based on diagnoses, co-exposure to medications, and then measures of healthcare utilization, which might be a sort of general proxy for health status. And the goal was to have robust confounder control through the inclusion of a large number of proxies in our study. So here's what we found. The risk of malformations was 6.3% in patients who were exposed to statins during the first trimester, compared to 3.6% in those that were unexposed. So the relative risk associated with statin exposure without controlling for any confounders was 1.79, nearly a 2-fold increase in the risk of malformations. Now, you can imagine if you did a registry study where you just enrolled statin-exposed patients, you would conclude that the risk of malformations in patients that took statins was higher than the baseline risk observed in the population. However, we know this is a confounded exposure because statin exposure is frequently occurs in patients that have diabetes and hypertension and other risk factors for malformations. So when we controlled for just the what we thought was the most important risk factor, most important confounder, diabetes, you can see our relative risk estimate attenuates down to 1.34. And then when we fully control for all of the confounders that we measure in our data, the risk estimate shifts to the null, suggesting there's no causal effect of statin exposure on increasing the risk of malformations in the offspring. So about 5 years after our study was published, the FDA requested that manufacturers remove the strongest warning against using cholesterol-lowering agents during pregnancy, and in their explanation for why this change was warranted, they pointed to our study and talked about our results. And this was I think a nice example of doing a study that really impacted on the way regulators view a particular drug. And I think the most important impact of this is, again, it lowers the burden to using these medications in patients of reproductive age who may very well benefit from the long-term benefits of decreasing their cholesterol in terms of heart disease or stroke risk in future life. So now I'm going to give a different example where regulators took our results and used it to change a label, but in a really different fashion, which is, again, I think quite interesting. So this was work that we've done on danzatron, the antiemetic, and congenital malformations. So all of you who work in perinatal care know that nausea and vomiting is very common in pregnancy. It affects about 80% of pregnancies. And the guidance is that recommends early treatment of nausea and vomiting in pregnancy for both maternal symptom relief, but also to prevent the progression to hyperemesis gravidarum, which is a really serious and potentially even life-threatening complication. Ondansetron, which is a serotonergic receptor antagonist, a 5-HT3 receptor antagonist, is the most frequently prescribed drug for nausea and vomiting in pregnancy, and is thought to be amongst the most effective, if not the most effective. So at the time we did the study, the available evidence on ondansetron and congenital malformations was both limited and conflicting. Some studies had suggested no increase in the risk of birth defects, but the number of women in those studies was relatively small. The largest study prior to ours had a total of 1,233 patients. There were other studies, primarily emerging from the case control design, suggesting a doubling in the risk of the malformations of cleft palate and in cardiac defects. But because these emerged from case control designs, there was concern around recall bias as well as the potential for residual confounding. And at the time we did the study, guideline organizations had urged further studies be performed. So we again leveraged this large claims data set that we have drawn from Medicaid beneficiaries nationwide, 1.8 million exposed patients by the time we did this study, of whom nearly 90,000 were exposed to ondansetron during the first trimester, the period when organ systems are developing, the period of organogenesis. The outcome for this study was congenital malformations, and we looked specifically at cardiac malformations and oral clefts based on prior studies suggesting an increased risk in these malformations, and then malformations overall, and again used algorithms that had a high degree of specificity. And then we, similarly to the statin study, drew from a wide range of covariates in claims to try to capture all of the relevant confounders, including diagnoses, demographics, co-exposure to other medications, and measures of healthcare utilization. This study was published in JAMA in 2018. And this just shows the range of covariates that we included. So we adjusted for treatment indication and associated factors, maternal demographic characteristics like age, race, state of residence, multiple gestations, medical conditions like psychiatric and neurological conditions, chronic conditions like diabetes, hypertension, renal disease, certain co-exposures, concomitant medication use like psychotropic medications, antidiabetics, antihypertensives, and then measures of the general markers of burden of illness like the comorbidity index, the number of distinct prescriptions for medications other than antiemetics, number of outpatient visits, et cetera. We did several levels of adjustment. We looked at the crude association, the unadjusted association, and then a level of adjustment where we adjusted for just treatment indications and associated factors. Another level where we adjusted for all of the confounding variables that we pre-specified. A further level where we adjusted for our pre-specified confounders, as well as using the high dimensional propensity score to empirically define additional confounders. And then we did a range of sensitivity analyses to test the robustness of our results, including comparing ondansetron to other antiemetics, looking at 2 dispensings for ondansetron during the first trimester, looking at a more narrowly defined exposure window associated with particular malformations, and then a negative control analysis. So here are our main findings, and there are 3 panels. There's a panel for cardiac malformations, a panel for oral clefts, and then a panel for any congenital malformations. And within each of these outcomes, we show 4 levels of adjustment. The unadjusted estimate, the first level of propensity score stratification, which was the treatment indication, the next level where we adjusted for all of the pre-specified confounders, and then the final level, the high dimensional propensity score, where we adjusted for all of the confounders that we specified, plus those that were identified in an automated fashion. So what you can see is there was a crude association, an unadjusted association between ondansetron exposure and cardiac malformations. However, after we fully accounted for confounders, that risk estimate shifted to the null, suggesting there was no causal association between ondansetron exposure and cardiac malformations in the infant. When we looked at congenital malformations overall, we see the same pattern, an increase in risk that shifts to the null when we account for all of the relevant confounders. However, when we looked at oral clefts, the pattern was different. So there was a 26% increase in the risk of oral clefts in the crude association. And even once we adjusted for all of the relevant confounders, the risk estimate was essentially unchanged, suggesting a 25% increase in the risk of oral clefts after accounting for confounding conditions, pointing to the potential for a small but causal link between ondansetron exposure and the occurrence of oral clefts in the offspring. So our conclusions were, after accounting for all the confounder conditions, we again observed no increase in the risk of major congenital malformations overall or cardiac malformations. We saw a small increase in the risk of oral clefts, but this risk estimate is smaller than other studies had previously suggested. We see a 25% increase in risk, which on the absolute scale translates to just 3 additional cases of oral clefts per 10,000 women who are treated with ondansetron. So very small absolute increase in risk. And these findings held up across a range of sensitivity analysis. So our interpretation of the results in the discussion of the paper were that these are generally reassuring data, that we do see the small increase in oral clefts, but it was much smaller than the case control studies that suggested a doubling of the risk. We didn't see an increase in the risk of the most common type of congenital cardiac defects. Nevertheless, the European Medicines Agency, about a year after our study was published, asked all of the manufacturers of ondansetron in the European Union to change their label and to include information from our study, which pointed to the elevated risk of oral clefts. And then, I think this it was something that I think is fine. This is probably something that should go into discussion with pregnant patients about the risks and benefits of taking ondansetron, this very small increase that's observed in our study. However, the EMA went further and they changed the label to say that ondansetron should not be used in the first trimester of pregnancy. So this, I think, raised a lot of concern on the part of patient advocacy groups, clinicians, people that were practicing in the EU, and there were a number of letters, including a letter that we were co-signatories on to the EMA, asking them to really think about this very bold statement that ondansetron should not be used in the first trimester. And the EMA, to my knowledge, has not yet gone back and made any adjustments to this change. So prompted by this, observing what the EMA did with our data, Krista Hybrex, Sonia Hernandez-Diaz, and myself wrote this viewpoint piece for JAMA Pediatrics. And we made a note that as large databases like the one that we employ are used, increasing numbers of statistically significant but weak signals of elevated risk around medications are likely to emerge. And we note that if regulators like the EMA or the FDA fall into the trap of deciding whether a drug is safe or not based on just statistical significance of the findings, they risk penalizing the most extensively studied drugs and pushing people to use drugs where there's less robust safety information. So we think as these signals of risk emerge, there's a real need to contextualize them with the safety of alternative medications, the benefits of treatment. And our recommendation in this piece was that regulators should generally not respond by contraindicating a drug like what the EMA did with ondansetron, but rather work with to communicate the risk to patients and clinicians, and then allow for real data-informed deliberation around the risks and benefits of a drug treatment for individual patients. And I think this points to a real need also for tools to help patients engage and clinicians engage in a real shared decision-making process and understanding of the risks. And to this end, this was an infographic that was developed by Rotunda Hospital in Dublin regarding this increased risk of oral clefts observed in our data. On the top panel, the figure represents the rate of oral clefts observed in non-ondansetron exposed pregnancies, the baseline risk in the population, and then the bottom panel, the rate of oral clefts in ondansetron exposed patients. So this is something you take to a patient and show them and say, okay, if you take ondansetron based on the best available data, this is what the increase in the rate of oral clefts looks like based on existing data. Okay, I'm now going to switch gears again and talk about recent work our group has done looking at opioid use disorder treatment in pregnancy. And all of you, again, practicing in perinatal care know that the prevalence of opioid use disorder is increasing, and that we're really in the midst of an opioid crisis in this country. The standard of care for patients with opioid use disorder during pregnancy is treatment with either methadone or buprenorphine. And there's good data to suggest that drug-assisted treatment, opioid agonist-assisted treatment, results in higher rates of prenatal care, decreased risk of preterm birth, a decreased risk of return to opioid use, and a decreased risk of overdose for pregnant patients. However, we know there are important differences between both methadone and buprenorphine, both in their pharmacologic properties, methadone being a pure opioid agonist and buprenorphine being a partial opioid agonist, as well as in the approach to administration. Buprenorphine can be dispensed as a prescription that patients take home with them. Methadone generally needs to be administered in a methadone treatment facility, although that is changing a bit in recent times. So the best data that we previously have had on the comparative safety of methadone and buprenorphine really derives from this trial, which was a very a landmark study for the field, the MOTHER trial, which was led by Henry Jones. And in this study, pregnant women with opioid use disorder were randomized to either methadone. 89 patients were randomized to methadone and 86 to buprenorphine. And then they evaluated neonatal and maternal outcomes in those that were followed to delivery. This was published back in 2010. And here's what they found. So the first thing to note was they lost a large number of patients in the course of the study, and they were not able to follow, despite really heroic efforts on their part, the course of all of the patients who were initially enrolled. 73 of the patients in the methadone arm completed their enrollment and were able to have outcomes assessed versus just 58 in the buprenorphine group. But you can see in those that they were able to evaluate, there was a strong trend towards a lower risk of treatment for neonatal abstinence syndrome with a odds ratio or relative risk of 0.7 with wide confidence intervals. And those that were treated had on average lower treatment peak NAS scores in the buprenorphine arm. They were treated with smaller amounts of morphine, and they had a shorter duration of treatment compared to the methadone group. Interestingly, there was a strong trend, but not statistically significant and with really wide confidence intervals towards a lower risk of preterm delivery in the buprenorphine group compared to the methadone group, and as well as a trend towards higher birth weight and a higher, more fetal growth, a longer length at birth in the buprenorphine compared to the methadone group. So this study was really important again because it established buprenorphine as a reasonable alternative to methadone for the treatment of opioid use disorder. Some of the limitations, though, included differential loss to follow-up. There were 33% of patients in the buprenorphine arm that were lost to follow-up compared to 18% in the methadone group. And that always raises the concern that that you're retaining patients who are healthier in one group than the other and not fully capturing the comparative effectiveness and safety of the two medications. Another limitation was comparative safety estimates were imprecise for many of the outcomes evaluated. And coming out of this, guidelines organizations recommended both medications, but identified comparative safety and effectiveness as an important gap in evidence. And so we published a study about a year ago now, and the lead author was our postdoc, Elizabeth Suarez, who's now an assistant professor at Rutgers, that sought to overcome some of the limitations of the mother trial. And our study was published in New England Journal back in 2022. So we again used our Medicaid cohort, 2.5 million pregnancies that ended in live birth. Of these, 10,000 were buprenorphine exposed, 10,704, and 4,387 were methadone exposed. We looked at the occurrence of neonatal abstinence syndrome and a range of other neonatal and maternal outcomes using validated algorithms. And then, as with the statin or ondansetron study, we controlled for a wide range of confounders and performed a range of sensitivity analyses. So here are our findings. So we observed that the relative risk of neonatal abstinence syndrome was 0.7 with very tight confidence intervals, you can see here. So the buprenorphine treatment was associated with a lower risk of NAS compared to methadone. And interestingly, the relative risk we observed was exactly the same as that of the mother trial, albeit with much tighter confidence intervals. When we looked at preterm birth, there was a strong and significant decrease in the risk of preterm birth associated with buprenorphine use compared to methadone use. Likewise, a decreased risk of small for gestational age or low birth weight associated with buprenorphine use. But importantly, there was no difference in the risk of maternal outcomes assessed, including cesarean section or severe maternal complications. And then this just shows the wide range of sensitivity analyses we used to test the robustness of our findings. And we observed across all of these sensitivity analyses, the results were unchanged. So our findings really support those of the mother trial, suggesting neonatal outcomes are more favorable following in utero exposure to buprenorphine than methadone. It could be a pharmacologic mechanism due to the partial mu agonism with buprenorphine compared to the full mu agonism of methadone. That's certainly biologically plausible for many of the outcomes that we assessed. Another hypothesis that's been put forward is that methadone dosing adjustments are not always made as to account for physiologic changes of pregnancy, and that this could result in episodes of micro withdrawal that could place strain on the pregnancy and lead to something like preterm delivery. Other limitations of the study include potential for residual confounding, although I think the fact that we do not observe a difference in the risk of cesarean section or severe maternal morbidity suggests that there is not a baseline severe difference in the health of patients in the buprenorphine or methadone arms. And given the magnitude of the estimates that we found, really strong imbalance, extreme imbalance in strong confounders would be necessary to explain the results that we observed. And so our results suggest, all things being equal, buprenorphine is probably preferred to methadone for the treatment of opioid use disorder. Now, there are certainly going to be clinical circumstances where a mother is been successfully maintained on methadone and is doing well with methadone, where the risks of the benefits of potentially changing to buprenorphine are outweighed by the risks of instability in the treatment course. And so for many patients, methadone may be the preferred alternative, continuing methadone into pregnancy. Okay, in the last couple minutes that we have together, I'm going to talk about long-term neural developmental outcomes associated with in utero exposure to medications. And this has been an area that our group and others have been very interested in. There's emerging data on the potential risks of adverse neurodevelopmental outcomes associated with the risk of with a range of medication exposures, including anti-epileptics, certain psychotropic medications. Our group has a paper that was just out yesterday in the New England Journal looking at valproate, topiramate, and lamotrigine, and the risk of autism spectrum disorder in the offspring. But these are really challenging questions to get at using databases because of the potential for strong confounding by indication, environmental factors that may be poorly measured in claims data, socioeconomic factors, lifestyle factors, certain illicit exposures. So this is a place where there's a real need for novel approaches to inform our thinking and our study design. So an example of some early work we did in this space was looking at the association between oxytocin exposure and autism in the offspring. And we know early exposures, prenatal exposures, are implicated in the pathophysiology of autism that derives from a large number of epidemiologic studies. And so there's been pretty robust interest in studying various perinatal exposures and the risk of autism in the offspring. Oxytocin, we also know, plays as a neurotransmitter a key role in social function and cognition, domains that are impaired in autism spectrum disorders. It's also, as all of you know, a drug that's used to induce and augment labor. So the hypothesis had been put forward that in utero exposure to oxytocin can cause downregulation of oxytocin receptors that may predispose to autism in the offspring. And this hypothesis really came to the fore when this study was published in JAMA Pediatrics back in 2013. So these investigators linked information on over 600,000 births occurring in North Carolina to educational records in North Carolina. And they were able to identify autism based on an exceptionality designation in the educational records. And they found that after they adjusted for the confounders that they measured in their study, induction of labor was associated with a 27% increase in the relative risk of autism that was statistically significant. And as you can imagine, any study that suggests that a common perinatal exposure is associated with increasing the risk of autism is something that is going to get a lot of attention. And there was a big media storm after this publication raising concerns about this potential link. And in fact, the American College of Obstetricians and Gynecologists issued a committee opinion after this publication suggesting that there should not be a change in current guidance regarding counseling and indications for and methods of labor induction, noting that avoiding inductions may lead to more stillbirths, cesareans, and adverse effects on both fetal and maternal health. So as I considered this North Carolina study and a lot of the things that were written afterwards about it, I was really struck by how weak the biological plausibility was. And to me, it just seemed like a situation where there was likely unmeasured confounding that was driving this finding. And so we set out to do a study taking advantage of Swedish nationwide population registry data. So in Sweden, they have really wonderful data resources for epidemiologic studies. All of the healthcare that's provided in Sweden is captured in their healthcare registries. You can link the healthcare registries to information about family structures using population registries. You can get a lot of information on different outcomes from the psychiatric registry, from the healthcare registry. You can incorporate information on neighborhoods and environmental factors. It's really robust data for epidemiologic studies. So we defined a cohort of all births that occurred in Sweden from 1992 to 2001, and then defined, and importantly for the design that I'm going to describe, family relationships using the families register. And then we were able to
Dr.
define
Bateman?
exposure based on in the induction indicator on the standardized delivery chart, and then the outcome of diagnosis, the outcome being a diagnosis of autism spectrum disorder based on the psychiatric registry and the healthcare registry.
Dr.
And
Bateman,
then,
I'm just going to let you know we've got about a minute or two before we go to Q&A.
perfect. I have, I think, 2 or 3 more slides. So I will finish in a minute. So we did a range of different modeling. We looked at the crude association. We then adjusted for stable maternal characteristics, individual birth characteristics. And then importantly, we did an analysis where we compared siblings, where we used a fixed effects model, where the contrast was made within siblings. So only siblings that were discordant with respect to induction status contributed to the estimation of effect. And this controls for all the factors that are shared by siblings and allows us to potentially make a more valid causal estimate. So here was our findings published in JAMA Pediatrics. Like the North Carolina group, we observed a crude association between induction of labor and autism spectrum disorder that persisted when we adjusted for measured stable maternal characteristics and persisted when we adjusted for all of the indicators for induction. So this is where the North Carolina study stopped. We did a further level of analysis where we did the sibling comparison, comparing siblings, one of which was born to a mother who was induced and another who was born to a mother who was not induced. And when we did that, the risk estimate shifted to the null, suggesting that induction of labor is not causally associated with an increased risk of autism spectrum disorder. So examining the long-term impact of medications in pregnancy is an area that is going to be really important to the field of medication safety in pregnancy, but it's important to do this in a robust manner using innovative designs such as the one I described. So this is my final slide. There are situations in which observational studies are going to give us the best evidence to guide clinical practice regarding the safety of medications. This is particularly true for pregnancy, where data regarding the safety of medications is lacking. To do these studies well, we need really meticulous attention to study design, analysis, and I would add interpretation. And getting this is really right. It's high stakes epidemiology, as the impact of these studies can have an impact on the treatment of millions of pregnant patients and their offspring. Just want to thank my close collaborators over the past 10 or 15 years, Krista Hybrex and Sonia Hernandez Diaz. And with that, this is my email if you'd like to email me, and otherwise I'm going to stop sharing and I'm happy to take questions. Thanks so much for your attention.
Thank you so much. That was an amazing presentation. I know I learned a lot, and we do have some questions coming in. So first, I think just to go back to this latest study on oxytocin and autism, considering that this study was done in Sweden, if you can speak a little bit to how applicable the data is from Nordic populations, maybe to the diverse US population and worldwide, and maybe speak to data at large and how those data sets are applicable to other population groups.
Yeah, that's a wonderful question, and something that comes up regularly. So in our studies that we're doing, our aim is really to define biological associations. We want to understand the biological impact of a drug on an outcome, independent of confounding conditions. So the results of any type of biological association that we find should apply to all pregnant populations, unless we could make the case that there are unique attributes of the population that would make the biological association different. And I think for most medication safety factors or the reasons why medications would be safe or unsafe, those should really not vary based on the characteristics of the population that you're interested in, and the biology should be retained. So I would argue that the Swedish study is very much transportable to the population in the US.
That's great. Similarly related to this study, do countries with national health systems have, quote, better data? And how do we navigate that with the search of data moving forward?
Yeah, I am always jealous of my Nordic collaborators because they do have such wonderful data because of the nationalized healthcare system. They capture information on all the patients that receive care through the Swedish healthcare system from cradle to grave, and there it is really just such a rich source for the kinds of studies that I described. Our group has a number of collaborations with Swedish investigators because the data are so rich. In the US, we're able to leverage claims data sets, commercial claims and Medicaid claims, but there's a lot of churn, meaning patients are enrolled and then they're disenrolled based on their eligibility criteria or switching jobs. And that can make particularly studying the long-term effects of medication exposure is quite challenging.
Mhm. Related to this study as well, how can you speak to how many births or how many women were enrolled in this study in the population registry data that you all use? I don't think it was
Uh,
included in this slide.
Let me see if I have it in my slides. I don't want to give you the wrong number. It was a large sample. Uh, yeah, I don't have it in. Um, I want to say hundreds of thousands, but I don't want to give the wrong number. So I'd
It's
have
okay. I think
um,
you have written here that it's about 9 or 10 years, so I imagine it's probably a high number. But the
yeah, no,
study is
it was
linked.
a comprehensive capture of all the births in
Mhm,
Sweden over about a 10-year period. So
mhm,
it was, and the impact it can be seen in the precision of the estimates. They're
mhm.
generally quite precisely estimated risks.
Can you describe how autism spectrum disorder was defined for the study?
Yeah, in that study, it was based on autism in the psychiatric registry and in the healthcare registry. So it was based on validated algorithms for uh, uh, assigning the diagnosis to the child in the Swedish healthcare system. It relies on a clinician making the diagnosis, so we don't have information on psychiatric scales or other instruments that might have been used. But once the diagnosis is confirmed by a clinician and entered into the registry, then
Mhm,
we would have access to it.
mhm. Great. Another question more broadly, how do you see today's political and legal climate related to reproductive health impacting studies on drug safety in pregnancy?
It's a great question. Uh, Non-live birth outcomes are an important and point for a lot of these, and so we're interested in using claims data to look at, and I expect, given the political climate and some of the legislation that's occurring, things may not be coded in the same with the same fidelity that they have historically, and that could introduce significant complexity, or particularly around studying non-live births. So yeah, an important question.
We have a couple questions related to the ondansetron study and some of your information there. Um, we have a question about if ondansetron is not to be given in the first trimester, if it's not recommended, what other alternatives might exist if some other vitamins and supplements are not working as well? If you can speak to that.
Yeah, I wouldn't want anyone to take away from this talk that ondansetron should not be used in the first trimester. That was the what the position that was that the EMA took, the European Medicine Agency. The FDA has not followed the lead of the EMA in that regard, and I would argue that ondansetron is perhaps probably the most effective antiemetic, and the antiemetic that we have now probably the best safety data on. So, I think there are a variety of different treatments that can be used, B6 uh, um, uh, or or other pharmacologic agents. But I wouldn't, Reglan, Phenergan, they're all alternatives. But But again, I wouldn't want people to change their prescribing practice based on my presentation here. Really, the EMA's decision around ondansetron, I think, had a lot of problems, and part of it is that some of these other medications have not been as fully evaluated, and so I think I would continue to follow the regular the guidance around treatment of nausea and vomiting in pregnancy. And if you were using ondansetron, I think it's fine to continue using it.
There's a related question if you recommend or know if it's recommended much to have a fetal echo if they use this medication in the first trimester.
So I think the best data, including our study, really does not point to an increased risk of cardiac defects, and so I don't think there would be an indication for fetal echo based on the existing data.
Let me see if we have any other questions coming in.
Okay. Well, thank you again for the opportunity to present. And if folks have additional questions, you can feel free to send me an email.
Yeah, this was an amazing topic, amazing conversation. Thank you so much for the presentation. It was wonderful and very insightful, very relevant to a lot of the conversations we all have with our patients every day. So thank you so much, everyone, for joining us.